We're going to be talking about the 3 levels of prevention, screening used in secondary prevention, and how we evaluate the quality of screening tests and interpret the results. This includes test validity, reliability, sensitivity, specificity, likelihood ratios, and predictive values. 100 years ago, infectious diseases were the leading cause of death globally, but thanks to public health, most of these deaths have been prevented. Immunizations are one of the most successful public health interventions. They prevent 2 to 3 million deaths annually. In addition to preventing morbidity and mortality from vaccine-preventable diseases, immunizations also save the health system overall and governments a lot of money. A cost-benefit analysis of 10 vaccine-preventable infections in 94 low- and middle-income countries estimated a savings of $44 for every $1 spent on vaccinations. This is a good example where an ounce of prevention is worth a pound of cure. I mentioned VAERS, the Vaccine Adverse Event Reporting System, in the previous lecture about public health surveillance. This is one of the national systems in place to ensure that vaccines that are approved by the FDA are safe and effective. The infographic on this slide compares the odds of different events to show that the odds of having a severe allergic reaction to the MMR or hepatitis B vaccine is very, very small. Severe allergic reactions to vaccines are extremely rare. The Haemophilus influenza B vaccine is a great example of decreased morbidity and mortality because of an immunization. Back in the 1980s, pediatric ICUs were full of kids with Hib. But in 1984, after the first polysaccharide Hib vaccine was licensed for use in children 18 months of age and older, you can see from the graph that Hib incidence immediately started to decline. And further declines in Hib incidence occurred after the first conjugate Hib vaccine was licensed, and then the Hib vaccines were licensed for use in infants aged 2 months and older. Most people today aren't even familiar with Hib anymore, even though it used to be a really common and serious infection in infants and young children. Preventive health is broken down into 3 levels. Primary prevention is when illness is avoided through health promotion activities and protective actions such as nutrition, hygiene, immunizations. Health promotion is enhancing well-being by empowering people to improve their own health. It recognizes that health is multidimensional and some factors are outside of an individual's control, such as those on the socio-ecological model I introduced in the first class. It's based on the principles of equity, social justice, and health for all. Secondary prevention is early disease detection and treatment. Screening falls under secondary prevention. In this class, we'll talk about the benefits as well as the risks of screening, the principles of screening, and sensitivity and specificity of screening tests. Tertiary prevention is limiting disability and rehabilitation following the diagnosis of disease. Tertiary prevention aims to improve quality of life for those with a disease. For screening programs to be possible, we need a disease to have a detectable preclinical phase, and for a diagnosis during that phase to change the outcome for the patient. For example, if detection shortly after the biological onset of a disease would not lead to prolonged life or improved quality of life or cure, then we wouldn't be able to do a screening program. It's only for conditions for which detection during this early phase of disease would change what happens for that person that we can decrease morbidity and mortality and improve quality of life with a screening program. The World Health Organization principles for early disease detection should be used as a framework for every screening program. The condition sought should be an important health problem. For example, we wouldn't do a screening program for a condition that is benign. There needs to be an accepted treatment for patients with recognized disease. It wouldn't do any good if we tested people for something and diagnosed them if there was nothing that we could do about it. Facilities for diagnosis and treatment need to be available. For example, it would be unethical if we did a screening program and diagnosed people but then didn't have any means of referring them for effective treatment. This is important to keep in mind in remote locations because it would be unethical to screen people for a condition if you don't have a way of getting the people access to care for the condition that you're diagnosing. There needs to be a recognizable latent or early symptomatic stage. If a disease is already in the late stages by the time it's diagnosed, it wouldn't be amenable to a screening program. There needs to be a suitable test or examination for the condition, which needs to be acceptable to the population. And the natural history of the condition, including development from latent to declared disease, needs to be adequately understood. There needs to be an agreed upon policy on whom to treat as patients. For some conditions, it isn't straightforward what counts as disease and what doesn't, but this needs to be clarified before undertaking a screening program. The cost of case finding, including diagnosis and treatment, should be economically balanced in relation to possible expenditure on medical care as a whole. For example, if it was very, very expensive to find a case of a condition and that condition wouldn't have a major impact on the life of the individual, it might not be worthwhile on the population level to implement such a screening program. And case finding needs to be a continual process, not a once and for all project. Screening is when we test a person without symptoms to identify an unrecognized disease. This definition is important to differentiate from tertiary prevention, in which the person has already been diagnosed with a disease. The benefit of screening is early disease detection and treatment, leading to decreased mortality from the disease or improved quality of life. But screening does come with risks. One of the risks is false positive test results, which cause stress for the patient and their family, and unnecessary investigative testing, which could be surgery or additional radiation that would otherwise be unnecessary. Screening tests can also cause individuals to incur additional costs, and there can be ethical concerns with screening, like what I mentioned earlier, where if someone is tested for a condition but they don't have adequate access to appropriate treatment, the test result could do more harm than good. A good screening test is easy to administer, inexpensive, causes minimal discomfort, has high validity, meaning it has a high sensitivity and specificity, and good reliability, meaning the results are reproducible. Again, for screening to be effective, the condition must have a detectable preclinical phase, and early intervention should alter the natural history of disease. Here's a practice question. You write a grant proposal to provide free hemoglobin A1C testing every 3 months to residents of a skilled nursing facility with diabetes, which has been identified as the subpopulation your organization serves, which is at risk for poor diabetes outcomes. Which level of prevention is this intervention? Is it a screening program? This intervention would be tertiary prevention because the people have already been diagnosed with diabetes and the objective is to improve their health outcomes. This is not a screening program. It's important to note that diagnostic tests and screening tests are not the same. Sometimes they're literally the same test, but when it's ordered in a different context, the results are interpreted differently. Validity is how good a test is at separating out the people who have the condition from those who don't. And reliability is how consistently the same result is achieved with repeated measurement. Sensitivity shows how well the test performs in people who have the disease, while specificity shows how well the test performs in people who do not have the disease. For screening programs, we usually want to test with a high sensitivity because we want to capture all the people in the population who have or who might have the condition of interest. And it's okay if we accidentally catch some people who don't have the condition with our initial screening test, because we usually follow up with a confirmatory test when doing a screening program. For most conditions, it's better to bring everyone in for follow-up care who may have the condition, rather than accidentally telling people they don't have the disease with an initial test, because then they wouldn't get treatment for the condition. 2x2 tables are used in your textbook, and they're a common way of conceptualizing how well a test performs. This method works well if you're trying out a new test and comparing it to a gold standard test. But it's important to note that this is an artificial way of looking at things that isn't usually how you'll apply these concepts in real life. True positives are the people who actually have the disease who test positive. False positives are the people who do not have the disease who test positive. True negatives are the people who do not have the disease who test negative. False negatives are the people who have the disease who test negative. So ideally, a perfect test would give you all of the results in the true positive or true negative squares, because all the people who have the disease would correctly be labeled as having the disease by the test, and all the people who do not have the disease would correctly be labeled as not having the disease by the test. But in real life, no test is perfect. So we often need to weigh whether we want to compromise sensitivity or compromise specificity, depending on what it is we're testing for and what the purpose of our testing use is. For screening tests, we usually favor a high sensitivity, even if that means not having a great specificity, because we want to capture all the people who might have the condition, even if that means having some people get a false positive test result. It's important to note that sensitivity and specificity are both fixed characteristics of the test. They do not change based on the prevalence of the disease in the population you're testing. We calculate sensitivity by dividing the true positives by the true positives added to the false negatives, which is everyone who has the disease. And we calculate specificity by dividing the true negatives by everyone who does not have the disease, the false positives plus the true negatives. A test that is negative in 9 out of 10 patients without a disease has a specificity of 0.9 or 90%. A test that is positive in 8 out of 10 patients with a disease has a sensitivity of 0.8 or 80%. You're the primary care provider for 1,000 people served by a community clinic in Utqiagvik. You recently evaluated several patients with fever, chills, headache, back pain, and generalized weakness. When you took a history to determine possible causes of illness, all the patients with these symptoms recently ate caribou they had hunted in the area. You suspect brucellosis, and there is a new test that can be performed in the clinic. Point-of-care testing would be a great alternative to antibody testing or sending out a Brucella culture to be grown in a lab, which takes many days. The manufacturer of this Brucella test you're considering purchasing for the clinic provides the following. 80 people who have brucellosis got a positive test result. 100 people who do not have brucellosis got a positive test result. 20 people who have brucellosis got a negative test result. 800 people who do not have brucellosis got a negative test result. We can use the 2x2 table method to organize the information provided. 80 people who have the disease got a positive result. 100 people who do not have the disease also got a positive result. 20 people who have the disease got a negative result. 800 people who do not have the disease got a negative result. Then we calculate sensitivity by dividing 80 by 100 for 80%, and we calculate specificity by dividing 800 by 900 to get 89%. This means the Brucella test in this example correctly labeled 80% of the people with brucellosis as having the disease, and it correctly labeled 89% of the people without brucellosis as not having the disease. The sensitivity is the true positives divided by the total population with the disease, and specificity is the true negatives divided by the total population without the disease. It's a helpful convention when using 2x2 tables to put the total population in the lower right corner. Your positive and negative test results should add up to equal the total number of people who were tested. This can be a helpful way of checking to make sure that you set up your 2x2 table correctly. Likelihood ratios tell us the ratio of the chance someone with the disease tests positive to the chance someone without the disease tests positive. Positive likelihood ratio, abbreviated LR+, tells us how much to increase the probability of disease if the test is positive. It's the probability of a person who has the disease testing positive, the sensitivity, divided by the probability of a person who does not have the disease testing positive, which is 1 minus the specificity. Negative likelihood ratio, abbreviated LR minus, tells us how much to decrease the probability of disease if the test is negative. It's the probability of a person who has the disease testing negative divided by the probability of a person who does not have the disease testing negative. A likelihood ratio greater than 1 indicates the test result is associated with the disease. A likelihood ratio less than 1 indicates the result is associated with the absence of disease. Before ordering a test, if you're a clinician, you always need to consider how it will affect medical management of the patient, and likelihood ratios help make this determination. This is also important to understand if you're going into public health and may be designing screening programs but are not a clinician. It's important to note that likelihood ratios are determined only by test sensitivity and specificity. So again, they're characteristics of the test. They don't change based on prevalence in the population you're testing. The higher the likelihood ratio, the better the test is for ruling in a diagnosis, and the lower the likelihood ratio, the better the test is for ruling out a diagnosis. Here's some more practice questions. What's the consequence of a false positive test result in the brucellosis example provided previously? If we tell someone they have brucellosis, but they don't actually have brucellosis. One possible consequence would be they might get treated with an antibiotic that might not be helpful for the condition that they actually have, and they may experience side effects they wouldn't have had they not been given the wrong treatment. What would be the consequence of a false negative test result? If we told someone they did not have brucellosis, but they actually did, that could be a problem because we would fail to treat them for the condition that they actually do have, and that may lead to long-term health complications. Therefore, for patient safety, your priority should be to choose a test with a high sensitivity would be the best answer for this example, because we want to label all the people who have the condition with a screening test, and we can follow up to confirm who actually does or does not have the condition with a second test. You want to know if the test is positive, how likely is the patient to have the disease, and if the test is negative, how likely is the patient to have the disease. When dealing with human health, a lot of measures are not a dichotomous result. It isn't as simple as yes or no. We often need to determine a cutoff point for continuous measures. For example, with blood pressure, people's readings occur on a spectrum, and we have to determine as a country or across countries what will count as high blood pressure and what will count as normal blood pressure. We have to make a somewhat artificial determination to draw a line between normal and disease. With the blood pressure example, if we put the cutoff point too high, we would fail to provide nutrition counseling and exercise counseling and medications to reduce the risk of heart attack and stroke in people with an elevated blood pressure that we mislabeled as having a normal blood pressure. But if we put the cutoff point too low, for example, if we said 100 over 70 millimeters mercury is the cutoff between normal and high, then we might erroneously give blood pressure medication and counseling treatment that wasn't necessary to people who actually had a healthy blood pressure. One example of a dichotomous test result in human medicine is PKU, which is an inborn error of metabolism we test infants for. The infant either is positive for PKU or negative. For dichotomous test results like that, we don't have this issue of having to make a decision where the cutoff value should be. The left blue shaded area represents the people who actually have the disease, and the white vertical area is the people who really don't have the disease. On the left are the test results after the entire population was screened. The circles represent individual people to show the distribution of test result values in this population. With the cutoff point like this, The test would correctly label 4 people of having brucellosis who do indeed have the disease, and it would incorrectly label 1 person as having the disease who does not actually have the disease. Meanwhile, the test would incorrectly label 6 people who have brucellosis as not having the disease, while correctly labeling 9 people who do not have the disease as not having the disease. What about the specificity now? It's not as good, but the sensitivity, it's much better with this cutoff point. Now we only have 1 false negative, but 3 false positives. When you increase the specificity, you decrease the sensitivity. Ideally, the range of normal and abnormal values wouldn't overlap, but with real screening test results, they usually do, which forces us to make a decision. We have to decide where to draw the cutoff point, knowing that increasing specificity minimizes false positives, while increasing sensitivity decreases false negatives. When the cutoff point is further to the right on the graph below, you get a lower sensitivity but higher specificity. When the cutoff point is to the left, you get a higher sensitivity but lower specificity. A lower cutoff, like on the left, is often preferable for screening, so you don't miss anyone with the disease because you typically follow up with everyone who gets a positive screening test result and retest them with a confirmatory test. To reiterate, moving the cutoff criterion line affects sensitivity and specificity, but in opposite directions. Changing the cutoff criterion from 1 to 2 decreases the number of false negatives, it increases sensitivity, but also increases the number of false positives. It decreases specificity. What happens to specificity if we move the cutoff point to the red line? The specificity would be 100%. Everyone without the disease would correctly get labeled as not having it. The take-home point is the choice of cutoff level depends on the relative importance of false positives and false negatives for the disease you're testing for. Predictive values are very relevant clinically because they answer the question, if the test is positive, how likely is it that this particular patient has the disease? Pre-test probability is the chance of having the disease before getting the test result, which is determined by the prevalence in the population and also takes account the individual's risk factors. Bayes' theorem tells you how to adjust pre-test probability to post-test probability. When you get a test result, you don't throw out the pre-test probability, you adjust it to interpret test results. Positive predictive value describes how likely it is that a positive test result in a given patient population represents a true positive. And negative predictive value describes how likely it is that a negative test result in a given patient population represents a true negative. We have to interpret test results in light of the risk group the patient comes from. High positive predictive value is very important for a disease for which a positive test result will result in invasive follow-up. For example, we don't routinely screen for ovarian cancer, but if we think that someone does have ovarian cancer, surgery would likely be necessary to confirm the diagnosis, which would be a high-risk intervention for the individual. A good rule of thumb is that a positive predictive value of at least 10% is needed to justify a screening program. If 9 out of 10 positive test results are correct, meaning they're true positives, then the positive predictive value is 90%. And if 7 out of 10 negative test results are correct, meaning that they're true negatives, then the negative predictive value is 70%. To explain predictive values, I'll turn what we talked about before on its side. Now the blue shaded area is horizontal rather than vertical. The same diagram is used, but this time the information we know is whether people got a positive or negative test result, rather than if they actually have the disease or not. This is more like the real-life situation when you get a screening test result back from your primary care provider but don't know if you actually have the disease or not, or if you're the clinician, whether your patient actually has the disease or not. Positive predictive value answers the question, if your test result is positive, how likely is it that you, the individual patient, actually have the disease? I know this may look complicated for some of you, but I'm showing the formula here so you know how the simplified equation was derived. The probability of the disease given a positive test is equal to the probability of a positive test if you have the disease times the prevalence divided by the probability of a positive test if you have the disease times the prevalence plus the probability of not having the disease times 1 minus the prevalence. P of B is the probability of a positive test result. The denominator of the longer version has true positives plus false positives because it's the probability of someone getting a positive result regardless of if they have the disease. This formula is for use when you have percentages rather than numbers. For example, prevalence of the disease rather than a count of cases of disease. Here's a practice question. To study this new test, I enroll 1,000 people with brucellosis and 1,000 people without it who have not consumed any caribou meat as a control group. After testing my study participants and calculating the sensitivity and specificity, I calculate the positive predictive value. The Alaska Department of Health contacts me to assess feasibility of a statewide screening campaign. Can I share the positive predictive value I calculated when helping them determine whether the screening test should be used for all Alaskans? Why or why not? No. In this instance, the positive predictive value will be way higher for this artificial population because the exposed group and the control group without the disease were the same size. So the prevalence in this artificial study population would be 50%. This is very different from a real situation where you would be testing a population of people whose disease status is unknown. In real life, you can look up the sensitivity and specificity of a test and the disease prevalence in the community you serve, but you have to calculate the positive predictive value because it's unique to your population. Predictive value is not a fixed characteristic of the test. For this example, the brucellosis test has a sensitivity of 99% and a specificity of 95%, and the population is 10,000 people. So we put the population total in the lower right-hand corner. Since we know the prevalence is 1%, we can multiply 10,000 by 0.01 to determine that 100 people in the population have brucellosis. We put this total below the column for those with the disease, then we subtract the 100 people with brucellosis from the total population to determine that 9,900 people do not have brucellosis. Next, we apply the sensitivity of 99% to the 100 people with brucellosis by multiplying. So 99 people are correctly labeled by the test as having brucellosis, and one person was incorrectly labeled as not having it. Then we multiply the specificity of 95% by the people who do not have brucellosis, 9,900 times 0.95, and that gives us people that are correctly labeled by the test as not having brucellosis. Then we subtract from the total people without brucellosis to determine the test would incorrectly label people as having brucellosis who don't actually have it. Then we can calculate our positive predictive value by dividing the true positives by the true positives plus the false positives. The test correctly labeled 99 people as being positive for brucellosis who do actually have the disease. So it's 99 divided by all the people the test labeled as being positive, which you can find by adding across horizontally. And that gives us a positive predictive value of 17%. So if a patient comes in from this population and they get a positive test result using this particular brucellosis test, there's a 17% chance they actually have the disease. Now let's look at what happens when we increase the brucellosis prevalence in the population from 1% to 5%. If we go through the same steps using the 2x2 table format, we then get a predictive value of 51%. So you can see when prevalence increases, the effect on predictive value is dramatic. Now let's look at the relationship between negative predictive value and disease prevalence. Negative predictive value is the true negatives divided by everyone who gets a negative test result, the true negatives plus the false negatives. With this test, when the brucellosis prevalence is 1%, we get a negative predictive value of 99.98%. And when the prevalence increases to 5%, we get a negative predictive value of 99.94%. So you can see from these examples that the negative predictive value isn't as dramatically impacted by an increase in prevalence compared to the positive predictive value. The positive predictive value is much higher in a population with a high disease prevalence. When something is rare, false positives will skew it a lot, but when it's common, the true positives are closer to all positives. This means it works well for conditions that are relatively common in the population, but it's less accurate for conditions that are very rare in that population. When deciding who to screen for a particular disease, it's especially important to have a high positive predictive value if a false positive test result will lead to invasive follow-up. A screening test is more likely to cause harm if the positive predictive value is low, for example, less than 10%, for the individual patient based on their characteristics such as gender, age, geographic area of residence, occupational exposures, and family history. This graph predicts that relationship between predictive value and disease prevalence, which isn't linear or entirely intuitive. Here's another practice question. If 80% of women with breast cancer have positive findings on a mammogram, then the probability that your patient whose mammogram just came back positive has breast cancer is 80%. True or false? That's false. If the positive predictive value for screening mammography in American women aged 40 to 50 is 0.04 and your 45-year-old patient gets a positive test result, what are the chances she actually has breast cancer? 4%. The positive predictive value is the proportion with the positive tests that actually have the disease. Positive predictive value describes how likely it is that a positive test result in a given patient population represents a true positive. The mammogram is a well-known screening test for breast cancer. Years ago, women were screened before age 50 even if they didn't have an increased risk, such as genetic susceptibility to breast cancer. Over time, it has become increasingly apparent, based on population-level data, that screening women under 50 with an average risk for breast cancer causes more harm than good. This is partially because younger women's breast tissue is more dense, which makes the mammogram harder to read. The risk of breast cancer also increases with age. The annual incidence of breast cancer in 40-year-olds is about 1 case per 1,000 women, while the incidence reaches about 5 cases per 1,000 at age 65. Another factor is that screenings we use today in modern medicine aren't nearly as accurate as people often assume. Imagine you recently had your first mammogram and your primary care provider informs you that your screening was positive, so you need to come in for additional imaging and a breast biopsy. Intuitively, you may think it's very likely that you have breast cancer based on your positive test results. After all, mammograms are considered to be a highly accurate tool for breast cancer detection. People often incorrectly think if mammography has a sensitivity of 81%, then my positive test must mean I have an 81% chance of having cancer. Remember that sensitivity refers to the number of people correctly identified by the test as having the disease when testing a group of people who are already known to have the disease. Like in the research study example I provided previously, where the control group is people who are known not to have the condition, and the exposed group is people confirmed already to have the condition. It's positive predictive value, not sensitivity, that's helpful in determining the likelihood of disease given a positive screening test result. If we assume you're a 40-year-old woman and use breast cancer prevalence data from a relatively small study that found a positive predictive value of screening mammography of 4%, that means given your positive mammogram, there's a 4% chance you actually have breast cancer. It's likely even lower than that, though. Large international databases yield a positive predictive value of 1.3% for a 40-year-old, although it increases to 9.8% at age 60. The increase in positive predictive value with age is important because it's after age 50, when it nears 10%, that the benefits of screening start to outweigh the risks. The first table shows breast cancer deaths avoided per 10,000 women screened by repeated screening mammography over 10 years. And the second table shows the harms of one-time mammography screening per 10,000 women screened. You can see in the youngest age group there's a higher rate of false positives and more breast biopsies are needed for confirmatory testing. In the 70 to 74-year-olds, there's a lower rate of false positives, and the false negative rate doesn't increase very much. It's a helpful rule of thumb to remember that in general, if a positive predictive value is less than 10, screening is usually not warranted. This graph shows positive predictive value by age group, and you can see that it's around age 50 that the positive predictive value gets above 10, which is when the benefits of screening outweigh the risks. If a woman completes screening mammography over 20 years, she has a 25% to 50% risk of receiving a false positive result after being called back for more testing or treatment. Screening causes a significant amount of overdiagnosis and overtreatment because non-invasive ductal carcinoma in situ, which is a cancer that often will not progress to cause negative health effects or death, is often diagnosed with mammography and then treated. Some of these cases do progress, but we don't have a way of determining which ones will, so all these women get treated to be on the safe side. In addition to psychological stress and medical bills, false positive results and overdiagnosis can lead to surgeries, chemotherapy, and radiation therapy for cancerous cells that never would have progressed to invasive breast cancer had they been left untreated. Getting regular screening mammograms for more than 10 years reduces the risk of dying from breast cancer by 0 to 15%, with the most well-designed studies finding the smallest benefit or no benefit. When 10,000 women are screened repeatedly over 10 years, 3 deaths may be prevented. These 3 deaths are at the cost of 1,212 women receiving false positive results, 164 women getting breast biopsies, and 10 women having cancer that was not detected by their mammograms. And again, this data is based on women of normal risk, so this does not include women who have the BRCA genes or a first-degree relative with breast cancer. On April 30th, 2024, the United States Preventive Services Task Force changed their recommendation for women of average risk to begin screening for breast cancer with mammography starting at age 50 to instead begin screening at age 40. This guideline change was intended to help address the disparity in Black women who are more likely to be diagnosed with more aggressive breast cancer before age 50 compared to other racial groups and have seen more increases in incidence of breast cancer, especially since 2016. With this guideline change, the United States Preventive Services Task Force did not make a recommendation regarding breast ultrasonography or MRI in women with dense breast tissue. And the recent data that led to the guideline change begs the question why they chose not to make different recommendations based on race, but instead made a blanket change to the age for all women to initiate breast cancer screening. A large cross-sectional study published earlier this year, in addition to several other recent studies, have shown that breast cancer incidence among women aged 20 to 49 has been increasing since the year 2000, with a sharp increase starting in 2016, with an annual percentage change of 3.76 every year since 2016. And when the data are broken down by race, non-Hispanic Black women have had a disproportionate increase in breast cancer diagnosed before age 50 since 2016. A large cohort study that looked at this data and analyzed the impact of different screening recommendations determined that to decrease the disparity between different U.S. races, Black women should start screening for breast cancer 8 years earlier than the general population at age 42 to have a 10-year cumulative risk of breast cancer mortality of 0.329%. And on the other end of the spectrum, Asian women should start screening 11 years later than the general population at age 61. Native American women fall in between and should start screening at age 57 based on this risk model. But the United States Preventive Services Task Force chose not to make race-based guidelines for breast cancer screening. But they did acknowledge that they made this change to address the inequities in breast cancer stage at diagnosis, subtype, and mortality among Black women in the U.S. Black women are more likely to be diagnosed with breast cancer beyond stage 1, more likely to be diagnosed with triple-negative cancers, which are more aggressive tumors, and Black women are 40% more likely to die of breast cancer compared to white women. Here's what the United States Preventive Services Task Force had to say about this guideline change.
Breast cancer impacts far too many people across the country, and we have long known that screening can help to keep people from dying from this disease. The latest science is clear that encouraging all women to start getting screened when they turn 40 can save even more lives from breast cancer. Black women are 40% more likely to die from breast cancer than white women, and all too often get more aggressive cancers at younger ages. So this new recommendation is even more important to them. Ensuring that Black women start screening at age 40 is certainly an important first step, but yet not quite enough to completely erase or reduce the inequities that we see. We still need more scientific evidence to help us to better understand whether and how additional screening might help the nearly half of all women who have dense breasts. We also need to better understand the health disparities that women face. And we need to better understand the potential benefits and harms of screening women ages 75 years and older. But for now, the most important thing for women to know is they should start getting screened for breast cancer every other year, starting at age 40, since it just might save your life.
The United States Preventive Services Task Force does not recommend routinely screening men for prostate cancer using a PSA blood test. After reviewing the available evidence on prostate cancer screening in American men and grading the evidence based on quality, an independent panel of experts determined that for most men, the benefits of the screening do not outweigh the harms. Even for men ages 55 to 69, the decision of whether or not to screen for prostate cancer should be individualized with a discussion of the potential risks and benefits of this screening. The decision should take into account individual risk factors and patient preferences. You can see from this infographic that out of 100 men who get a positive biopsy, 20 to 50% of these men will be diagnosed with cancer that would never grow or cause harm. But most men who get a positive biopsy then get surgery or radiation, and many are left with erectile dysfunction and urinary incontinence. Of 1,000 men offered PSA-based screening, 3 out of the 1,000 men will avoid cancer that would spread to other organs, 1 prostate cancer death would be prevented, and 5 of those 1,000 men will die of prostate cancer even after surgery or treatment.
My name is Alex Christ. I'm a family physician and the vice chair of the U.S. Preventive Services Task Force. For 20 years, I've seen patients, taught residents, and done research at Fairfax Family Practice and Virginia Commonwealth University. The U.S. Preventive Services Task Force is a group of independent volunteer experts in evidence-based medicine and preventive medicine. We work to improve the health of all Americans by making evidence-based recommendations about prevention. Prostate cancer is one of the more common cancers to affect men. Based on a review of the evidence, what we're recommending in 2 parts is that men between the ages of 55 and 69 who are considering screening talk with their clinician, understand the benefits, understand the harms, weigh their values, and make a decision with their clinician. And we're recommending that patients 70 years of age and older not routinely get screened for prostate cancer. The screening test for prostate cancer is a blood test called a PSA blood test, or prostate-specific antigen. This can be elevated for men who have prostate cancer, but it can also be elevated for many other reasons. What the science tells us is that among men who choose to be screened, about 1 in 1,000 won't die from prostate cancer, and about 3 in 1,000 won't get metastatic prostate cancer. However, we also know from the same science that there are harms from prostate cancer screening. And while a few men will have benefits from screening, many men will have harms from screening. The harms include 3 things. The first harm is false positives. So a false positive means that a man has a high PSA test, but they don't have prostate cancer. That might lead to a biopsy, which can have some complications. The second harm that we think about is what we call overdiagnosis. And prostate cancer is a unique cancer. It grows very slowly. Most men who get it will never know they have it. They'll never have signs. They'll never have symptoms. And they'll only know that they have prostate cancer by getting screened for prostate cancer. We're not very good at figuring out which cancers are overdiagnosed and which ones will progress and affect a man in his life. So these men might get treated, and it might be a treatment that they don't really need. Third harm we think about is the harm from treatments, like surgery and radiation. And that can lead to urinary incontinence and erectile dysfunction. and that can really interfere with a man's quality of life. Now, one of the problems that we have with the science is thinking about high-risk men. So men who are African American or men who have a family history of prostate cancer. Does screening help them any more than an average risk man? We also don't know, do they have greater harms from the whole screening process? We need more studies to know what's right for high-risk men. And for high-risk men, we're saying that our current recommendations apply. The task force recognizes that the decision about prostate cancer screening is a complex and a personal decision. We encourage patients to talk with their doctor and make a decision together about what's right for them. For more information, visit uspreventiveservicestaskforce.org.
Herpes simplex virus can cause sores on the mouth and genitals. In general, HSV-1 infects the mouth and HSV-2 infects the genitals, but these viruses are very closely related and either type can affect either part of the body. Once a person gets infected, the virus will always remain in the body even if no sores are present. When there are sores on the skin, the virus can spread easily between people by skin-to-skin contact. When a patient with sores comes in for treatment, if it is unclear to the provider if the sores are caused by HSV or another type of infection, such as a bacterial skin infection, the sore can be swabbed and tested in the lab to confirm the cause. This testing is diagnostic testing, not screening, because the person in this example already has symptoms and the test is being used to clarify the cause of disease. People with no symptoms of herpes sometimes ask to have a blood test to screen for HSV, but this is not recommended by the United States Preventive Services Task Force. The positive predictive value for HSV-2 blood testing in an American is 50 to 75%, depending on the specific test used and the timing during the natural history of disease. This means that if you get a positive test result with the most widely used test, there's only a 50% chance you actually have HSV-2. So flipping a coin would be equally effective to predict whether or not you have the infection. Let's revisit the brucellosis example. The prevalence of brucellosis in this part of Alaska is 1%, and the new test you're using as a screening has an 80% sensitivity. When using the 2x2 table method, you can make a fictitious population to help fill in the rest of the table. Let's say there's 1,000 people in the population. We know the prevalence is 1%, so we multiply 1,000 by 0.1 to determine that 10 people in our fictitious population would have brucellosis. Then we subtract the people with the disease from the total population to find how many people do not have the disease. 10% of those with brucellosis will test positive, so we multiply 990 by 0.1 to get 99 false positives. We subtract the false positives from the total population without the disease to get the true negatives. The test has a sensitivity of 80%, so it'll correctly label 8 out of 10 people with brucellosis as positive, and the other 2 who actually have the disease will get negative test results. That means for every 1,000 people screened, 99 will get a false positive test result. So you can provide some reassurance to your patient with a positive result by telling him there's only a 7% chance he actually has brucellosis. Your classmate working in Juneau calls. Her patient has never traveled to other parts of the state and follows a strict vegan diet, but he convinced another clinician to order lots of screening tests for him because he wanted to get checked for everything. Given the prevalence in the local community's wildlife and route of transmission for brucellosis, how does this change your calculations? How should your classmate interpret the positive test result in this patient? Your classmate should interpret this as a false positive. You don't actually even have to do any math. In this example, transmission would be nearly impossible, so the pre-test probability was extremely low, meaning that that test shouldn't have even been ordered in the first place, but because it was, that result is not likely to represent a true positive. Test results need to be interpreted taking into account pre-test probability. How likely is it that you have the disease before you know the test result? For example, if someone is obese and both their parents have diabetes, and they're from an ethnic background with a high prevalence of diabetes, then the pre-test probability before getting screened for diabetes is high. Bayes' theorem tells us how to adjust pre-test probability to post-test probability. You don't throw out the pretest probability, you adjust to interpret the test results. This brucellosis in a vegan example is a pretty clear-cut case, but in most situations, it's more nuanced. In summary, the goal of screening is to catch early signs of disease before symptoms develop when a cure is more likely. No medical test is 100% accurate, and screening tests always come with a chance of a false positive or a false negative result. Screening tests are intended for use when there's a high prevalence of the disease in the population the patient belongs to. A personal and family health history is needed in combination with data for geographic area, gender, ethnic background, lifestyle, and other factors to determine how likely it is that you have the disease before testing, the pretest probability. If a screening test is used when there is a very low pretest probability for the individual, false positive results are more likely, and it's less clear how the results should be interpreted. Potential harms of screening tests include psychological stress, unnecessary procedures and treatments, and the cost, time, and health risks associated with these. Benefits of screening include catching diseases early when they can be cured or effectively treated. To recap, this lecture introduced the 3 levels of prevention. We discussed screening tests used in secondary prevention and how we evaluate the quality of a screening test and interpret the results. This includes test validity, reliability, sensitivity, specificity, likelihood ratios, and predictive values. Next lecture is about the dynamics of disease transmission, outbreak investigation, and measures of risk used in epidemiology.